Assalamu alaikum. We are going to talk today about an important topic, namely the aortic arch, what's being done, where we're going, and what are the advances in the near future. It's an important topic. As you know, thoracic stents have revolutionized the treatment for thoracic aorta or for many pathologies that were very difficult to treat in the old time. Since the past 20 plus years or more, actually, since the past probably 25 years or so, thoracic stents have added a significant advances and improvement in the treatment of thoracic aorta. If we are going to talk about the arch, one has to be aware of what's going on in terms of treatment for the ascending aorta. Pathophysiology, it's a lot of times if you do an endovascular treatment, you have to use the ascending aorta as a landing zone, and even with open surgical treatment, a lot of times you replace the ascending aorta. So ascending aorta becomes, or the awareness of the pathology and the treatment and the future direction for the ascending aorta becomes a very, very pertinent in this presentation as well. I'm going to really talk in general topics. Obviously, the ascending aorta is a highly experimental at this time. Very few centers do that. Arch, two branch devices are no longer really experimental. They're mainstream. They can be used in specialized centers as well with experience. But in this presentation, because of the complexity of the treatment and pathology, I'm going to talk in general terms to give you an idea what we are doing or what's being done right now and where we're going with the future. And as you know, the most advances have been done in the thoracic aorta endovascular. But for both open and endovascular treatment, one needs to be aware of the integrity of the tissue, whether the patient has connective tissue disease, dissection, redo surgery, aortic valve, mechanical valve, bioprosthetic. For endovascular treatment is limitation why these ascending grafts, and for not too long ago the arch grafts were just difficult to use because of risk of stroke, endoleaks, anatomical profile, needs sometimes valve replacement. So you have to, a lot of times if you have a type A dissection with a valve, for example, the insufficiency, or you have congenital disease and you have bicuspid valve or something, you need a valve replacement, and that was an issue with doing these procedures in the past. Also the root of the aorta, how the root looks like, how the coronaries look like, and all of these considerations have to be thought about in order to have a successful endovascular treatment. And also the size of the aorta. So you cannot really, in this current age, you cannot do endovascular treatment if the size of the aorta more than 38 millimeter, or the root is not healthy, is dilated. For aneurysmal disease, it's very limited endovascular treatment, although there are studies now looked into eligibilities for those patients who has ascending aortic aneurysms, and it was pretty good, favorable outcome in this, and we'll go through that throughout this presentation. Again, other things you have to look at in these cases, in these type of cases, is the distance between branches, the takeoff, the angulation, the ascending and descending size discrepancies, because a lot of times the ascending size discrepancy, the ascending sizes or the ascending diameter a lot of times, but not always, is bigger. So if you have descending aneurysms, arch aneurysms, so all these things you have to look at. You have to look at these basically points here to make sure that you have a successful arch branch graft deployment. Other problems unique to the arch are increased pressure, so therefore migration forces are higher. Coronary arteries, and sometimes they're in the way, and there's not enough landing zone. Images difficulty, for instance, sometimes discrepancy between diastole and systole can be different in terms of the diameter of the aorta. Dealing with the left ventricular function and valve, basically, and the left ventricular is working, it's pumping. So all of these considerations should be accounted for, and then need to whether you need somehow to slow down the heart or stop the pressure, either with the rapid pacing, or sometimes people put a balloon in the SVC, and also delivery system, and sheath size, and how do you basically deliver the graft into the aorta, ascending aorta. So just again, this is an example where you have a discrepancy between the aortic diameter during the systole and diastole. So as you see, this is on the left hand side, you see the aortic diameter is 27.2 millimeter during diastole, and you see the innominate vein very, very clearly. At the time of dystole, this diameter increases to 31.3 millimeter on IVUS, and you don't see the innominate vein anymore. This is within normal blood pressure. So the systolic blood pressure is 112 over diastolic 72. So that just gives you one of the challenges that, if you place a stent, sizing could be an issue as well. In terms of indication for ascending stents, aortic dissection, pseudoaneurysms, penetrating aortic ulcer, intramural hematoma, aortic rupture, and aortic aneurysms. So let's just talk about two here. The aortic dissection can be chronic or acute. Acute, usually is done in those patients who cannot tolerate open procedure and meet certain criteria. It can be done with the percutaneous valve and without. It's being done. There are some CT reports showed that significant number of aortic type A dissection actually can be a candidate for ascending graft. In terms of aneurysms, the issue with aneurysms is a landing zone. If you do not have a landing zone, it's going to be very difficult to do aortic aneurysm repair adequately. Therefore, the newer procedure, which we are going to briefly touch on, called endovascular procedure, this doing aortic aneurysms now it's feasible with endovascular. I will talk a little bit more about it. Others, such as endoleaks and things like that. And probably the most common that we do this procedure for is probably pseudoaneurysms. About 15 years ago, or maybe 14 years ago, I'd say 13 years ago, one of my mentors started the first U.S. physician-sponsored institutional device exemption to study the ascending grafts. So initially they did this on the 3D printing, and they made sure that actually the device can be delivered and deployed, etc. The study was published then afterward, feasibility study that showed, based on 6 patients, successful deployment, 1 mortality, and basically 1 stroke. And in 2017, Dr. Wheatley has published a meta-analysis with 118 patients. Most common indication, in my experience, pseudoaneurysms to place an ascending stent, aortic dissection, could be chronic or acute. Acute, oftentimes these patients are too sick to have an open procedure, therefore it was used initially as a bridge to save these patients' life, make them feel better, then take them back and do Bental or hemi-arch or whatever they need to do to save the patient's life. PAU, it's relatively common. IMH, aneurysms is really hard to seal an aneurysm in the ascending aorta for many reasons. Is the force, is the distance, no landing zone. Sometimes the distance between the coronary arteries and the innominate artery is very, very short. It's shorter than 10 cm, and we don't have specific grafts for the ascending aorta to really be compatible with the physiology, the length, the width. That's another difficulty that one has to really take into the account. Aortic rupture, ascending graft could be really life-saving procedures for these patients, because you save their life and then you can fight another day. Again, when you have rupture, when you have really a dramatic, life-threatening condition, your goal is really to save the patient's life, not to do the perfect operation. You're in, you save their life, you stop the bleeding, and you're out. They get better, you fight another day. And that's perfect, solution for a condition like that. The other thing that I wanted to say, if you think about it, the improvement in the arch grafts and the now the two branch arch grafts are no longer experimental. They're out there. They're commercial in Europe. In the United States, they're still in trial. But or with Gore single branch device, it gives you a lot of flexibility in an experienced center or experienced operator, that you can even do a nice ascending graft with a innominate branch, or to save someone's life. It's doable if you have the experience, the team, and so forth. So technology is really the whole point of this presentation that I'm trying to achieve, and I'm trying to be careful. I don't want to be saying too complex or too experimental stuff, but this field is growing fast. In the next probably 5 to 7 years, these devices will be available commercially, and we're there. Many people are doing them, and it's worthwhile understanding the pathophysiology and the indication and how you can utilize these devices. And this feasibility, in this meta-analysis, showed that basically these devices are best served when you have a patient who is not an operative candidate, and that's true at the time, and maybe true now. Operation, it's always good, but we don't have perfect devices in the ascending aorta. The endovascular approaches for acute type A dissection, based on a CT feasibility study. This study was done in France by Dr. Holland, where they looked into a multiple CT scans, 102 CT scans for patients with acute type A dissection, and they hypothetically looked how many of those patients would have been a candidate for an endo procedure, and the answer was shocking, almost 50% of those patients. So that tells me that once the technology is better, 50% or close to 50% of those patients would be done endo, as opposed to putting somebody on pump, and this is a very morbid operation, obviously, with relatively higher mortality, especially in the places where they don't do them every day. The endovascular repair for type A dissection, this has been multiple reports in the literature, and as you see, the mortality is relatively low. Stroke is always an issue, but it's feasible. It's not statistically significant, it's very heterogeneous, but the point is, when people desperate have done this and they got away with it. The earlier cases that was started in our institution, look, it's It's basically a ascending dissection, and you see the 3D reconstruction. And I just wanted to show you, I put this slide to show you, look, this aortic valve, and you see how hyperdynamic the area is. So try to picture, being precise and place a stent without covering the coronaries or the innominate with this type of force. It's incredibly difficult. That's why we go with rapid pacing for these patients. Or in those days, actually, when this case was done, we used to give a very high dose of adenosine to stop the heart momentarily, and that's like about maybe 30 milligram of adenosine. We don't do that anymore. At least we don't do it, but we do rapid pacing. In Germany, they place a big balloon in the SVC and they shut down the preload, and the patient heart stops essentially for a little bit. If you look at this study and you see the reconstruction for the dissection, and you see different sections and the angle of the C-arm, and then you look at the IVUS picture here on top and left hand side, you see the innominate artery, and then at the bottom you see the coronary arteries, and you have to precisely place the stent in between, and this is not easy actually, but you look, the stent was placed, and you look the IVUS after the stent in comparison to previous studies. There's no flap, and it's very hard to place. You can't make mistakes here. That's the problem in these cases. You cannot make any mistake, because any mistake will cost you dearly. So you have to be very, very careful. And this is not an ego thing. You have to be humble. You have to have a team in place, and the team is consistent of a cardiac anesthesiologist, a cardiac surgeon, vascular or endovascular operator who have experience of doing TVARs and things like that. And you have to have skilled technicians. You have to have appropriate imaging studies, IVUS, TEE. You have to have the right people, and cardiologists, you have to have a cardiologist as well. Everybody has to work as a team here, and only this way you can have successful results with this. And look, this is after the stent placed. You see the flap is improved. The valve, there's no regurgitation, a little bit of regurgitation, but it requires a lot of skill to place the stent adequately without a problem, as well as it requires, like I said before, as a team. And that case was done, one of the first cases. This is probably later on was done, and this is for pseudoaneurysm. You see where the arrow is, pseudoaneurysm in the ascending aorta. Again, the distance between the innominate artery and the coronary artery here is crucial, because we don't have most of the time, we don't have commercially available device that can actually fit this area. Area is also sometimes is larger. It's 4 centimeters, 38 centimeters. Sometimes so basically more than 38 in the IDE that was our institution involved in. Will rule those patients out. You look at the follow-up for that first case that I showed you, and you see this is another case with the pseudoaneurysm. This patient came in with pseudoaneurysm where you see the arrow, and then that was done in 2014. In July, 3 months later, you see it's remodeling, and then you look in 2015, almost the entire aorta looks pretty good at that time. So it's important to follow up on these patients, and important to have the tools to fix any problems that can come up at the time. This is a case that I wanted to share with you as well. This is basically a ruptured or probably anastomotic dehiscence or pseudoaneurysm from type A dissection. The patient underwent graft placement some times ago, and he had a large pseudoaneurysm, and as you see, this pseudoaneurysm is behind the sternum. It's very challenging when you have a redo surgery with this size of aneurysm right behind the sternum. It's very challenging technically. You almost have to put the patient on circ arrest right away, through a fem cannula, and you can go in there. But having a stent graft is blessing if it's feasible. So in this case, as you see it's a very, very large pseudoaneurysm here. And in this case, and the patient is sick. Notice the pacemaker there. So these are not, healthiest patients that we do these procedures on. These are very ill patients. This patient's ejection fraction was in the 30s, or I believe it's 30%. I don't remember exactly how low it was, but it was very low. And you see delivering the graft through this acute angle in the arch sometimes takes a skill. You have to sometimes even place the wire in the basically in the heart. Yeah, and sometimes if you have mechanical graft, there are special devices where you have short tip. Some people develop techniques where you can go through the leaflet of the mechanical valve and do it that way, but it's quite challenging to get the wire and be in that area. And then you see here, once the graft is placed, graft is deployed, and you see the picture here. Basically the angiogram showed no pseudoaneurysm. It's completely excluded, and this is the picture here you see. And then you see the follow-up. From this was done in 223, and you see just short-term follow-up. And if you follow up just a few months, and then until now, you see the pseudoaneurysm has completely remodeled. So this was a success case, successful case, success story, that would help these patients. So it's very, very important, again, to have the right team, the right skill. You cannot, a small mistake can kill the patient in this case. While technically maybe it's not very hard, but it is hard to do everything right and deploy it really in the precise fashion. But I'm trying to tell you here that these stents and these procedures can be potentially life-saving, especially now we're doing these procedures in an experimental fashion, only in patients who cannot have other procedures, open procedures done. And this is another case where I wanted to show how important that distance between the innominate and the coronary arteries, basically. And this is somebody who had pseudoaneurysms, came in with severe mediastinal hematoma and rupture in the ascending aorta, and you see the hematoma is pretty big, pretty large, and again, you can do it open, but oftentimes these patients who are enrolled in these studies or in these cases are fairly sick. So you see the angiogram here shows a large blush bleeding in the ascending aorta. You see the coronary arteries, you see the valve, and you see the aorta quite tortuous, and you see the pigtail inside the heart. So in this case, you choose a gore graft. We deployed it outside of the body, about 2 stents or so, and like you see here, we measured it, and then we cut it, and then we placed it back in with umbilical tape into the sheath, and we deployed it. And you see the deployment is just normal deployment. You unsheath it basically. Just you put in a large sheath and you unsheath it, and that way you deploy it like that. And of course, this is done very quickly. Some people work on the patient, and some people work on the back table in these type of situations. So you have to have a good team. And as you see, is this complete coverage of the area that's ruptured. The innominate is open, the coronaries are open, and the patient did very, very well. And again, I'm not trying to make you do this. I just wanted to let you know what's out there, and what's basically upcoming. These are highly experimental still, but if we are talking about the arch, ascending stents become an important entity that one needs to be aware of. And now just briefly about the endobintal procedure. So there's if you go on PubMed, and I could not have large enough screenshot to have, there was more than 2 pages full of reports, studies. So this has been done a lot now in some places. In Atlanta, there was a case report. In Maryland, there was 5 case reports. In California, there's a lot of places where this endobintal has been done. It's all experimental, all off-label. I don't think there's an IDE for it yet. We started off with in Brazil. So, and we'll go over that in a little bit. But I wanted you to, when we talk about endobintal, so bintal procedure, first of all, for those who forgot what it is, it's replacement of the aortic valve and ascending aorta, and oftentimes done for type A dissection when you have aortic regurgitation and so forth. In endobintal, basically you replace the valve and you replace the ascending aorta, but you have to do something with the coronaries. So far the case reports that have been published and people who have done this, basically they have 2 types. One, a branched, so they used a branch that's like a thoracoabdominal aneurysm with a branch technology and then with a tapered graft, or they used a fenestrated graft, again tapered as well, with a fenestrations where the coronary arteries. And this is a patent one of people I know that I borrowed from. But these are the 2 concepts out there. It's fenestrated with a for coronary arteries and branch technology. This case here, on the left hand side with the big heart here, that's the first in man or in human being that was actually endobintal procedure done. And this is for a failing paramount AVR or aortic valve repair and aortic pseudoaneurysms. The patient was sick. They elected to do endobintal. What they did, they reconstructed the graft with a tapered graft, and the branches, as you see here, this is the inner branches, how they look like. And they did the procedure. So they deployed the branch, then they cannulated the coronary arteries from the branch, exactly like you would do for thoracoabdominal. And they successfully completed the procedure, and then 4 months later, you see the branches or the coronary stents are wide open, and I think they used fluency stents for these in this procedure. And this is a 3D reconstruction 4 months later. So that was the first in man endobintal procedure that was done and was successful. Again, you go on PubMed, there are 2 pages now worth of reports. So there's a lot of people did similar things, mainly fenestrated. Again, like anything else, this study, when you do these things, you try to do a 3D printing, make sure it's feasible, make sure you can do it. And this is a report by Holland group in France. They did a 3D model and they looked into the feasibility of fenestrated coronary artery stent, and it's feasible. If you look at, remember I talked about aneurysm, ascending aneurysm. This study out of Germany, at Hamburg, from Hamburg, they looked into 29 patients with ascending aortic aneurysm, and they looked into the feasibility of endobintal procedure. And what surprisingly, they found about 75.9%, so essentially 76% of the 29 patients that they looked into had feasibility to undergo endobintal procedure. So this is just, we are in the infant stages for that, but the technology is going to get better, and we are going to be doing these probably in the next somewhere between 5 and 10 years. Probably this would be already available commercially, I think. Anatomic feasibility, again, this is another study. They looked at the anatomic feasibility in 167 patients, and they found 2/3 of these patients with type A dissection, with acute type A dissection, are potentially or potential candidates for treatment with endovascular valve carrying conduit, meaning endobental. And again, they emphasize that tapered graft would be required because of the valve, the aortic root, and so forth. But again, there's a feasibility out there, at least theoretically. There have been case reports, multiple successful case reports, and this is coming. This is what's out there for the future, and this is is going to be an integral part of what we do for the arch and the ascending aorta and dissection. So this is actually very good news.